Hello? Hello? Hi, Juan.
Hi, it's Juan.
Hi, Juan. I'm going to make you the presenter, okay?
Okay, sounds good.
So I think what that'll let you do is just let you bring up your screen. Are you familiar with the sort of toolbar?
Yes, I believe so. Let me just, give me 1 second. Okay.
You got it.
Great.
Awesome. How's your son feeling?
He's better, thank you. He, oh, I guess I shouldn't make this. Give me 1 second. He, his fever's done, so that's good. His fever's gone, but he's left with a cough, and, you know, when they have a cough, you can't really take them to school.
Right.
So, let me just stop sharing real fast. How are things over there?
Things over here are good. Starting to write a report for Kaiser. That's always fun.
Yeah. Good time.
Yeah. And I'm visiting the 2 Maryland sites this week and next week, so it'll be nice to be able to leave the office again.
Okay.
We have some new faces on the call, new voices on the call. So I'm Jordana. I'm the program manager of Hallways to Health here at the School-Based Health Alliance. In the room with me is...
Hey, folks, it's John Schlett, the Alliance.
And I'm Anna Kern here. Great. And Juan, you want to go ahead and introduce yourself?
Yeah, good afternoon. My name is Juan Taisan. I'm the Associate Director for Programs here with the California School-Based Health Alliance.
Great. Molly, go ahead.
Hi, I'm Molly Baldridge. I'm the Adolescent Health Program Manager with the California School-Based Health Alliance.
Great. And I saw Sapna.
Yes, hi, this is Sapna Hensinski. I am the Project Manager with the Maryland Assembly on School-Based Healthcare.
Great. And I see Kara Ann is also on from the Alliance. Kara Ann, go ahead.
Hi there, Kara Ann McGray, School-Based Health Alliance.
And Stacy.
Hi, this is Stacy Moody. I'm with JSI Research and Training, and I'm a consultant, and I'm going to be joining, you've all heard from me via email, but going to be joining you to help work on sustainability, and really, really excited to be working with you.
Stacy, we're so excited to have you, and thank you so much for joining us on this first call and presentation, and we're looking forward to all of our work with you on this initiative. So without further ado, I think Monica and Lori will be hopping on in a moment, but I am recording the call, so I know that Juan, your son, is not feeling so well, so I want to let you get started, and we will let them jump in when they can. Okay?
Sounds great. Thank you.
You already have the presenter screen, so you should be able to advance the slides.
Cool. And everyone can see my slides, correct?
Yes.
Great. So good afternoon again. Thank you all. I apologize. I do have 2 sons who are toddlers, and they're always sick, and we've been dealing with like some kind of cold or flu since December, so it's very fun. but I wanted to make sure that we proceeded with this presentation. You may hear him coughing in the background, but for the most part, I think he's relaxed. So today what I wanted to do is really present on our work. Really, we call this our healthcare reform work, and for us, it's looking at the role of school-based health centers in the healthcare delivery system. It's very specifically in the healthcare payment system. And how do we ensure that school-based health centers are both effectively integrated into the delivery system and all that means, and then that they're reimbursed for a lot of the good work that our school-based health centers do. As most of you know, a lot of the work that school-based health centers do on a daily basis does not get reimbursed. Kind of the school-wide education, the health fairs, the case management, all the classroom presentations, a lot of that health education, which is so critical to the development of youth and young people, often is unreimbursable services or unreimbursable services from the health payer side. And so school-based health centers have to rely on nonprofit funds, philanthropy, or they simply eat the cost or try to find other ways and strategies to build. So that's what I'll be presenting today. This is an updated version of a presentation we did in February with our senior policy analyst here at CSHA. So if you've seen it, it will be somewhat the same. I'll try to go over different, I will be going over different points, and I want to talk more about the process of our work rather than just focusing on the outcome. So here's some of our objectives, just so everyone, my hope is that everyone gets a better understanding of our work, that you walk away with some new ideas for engaging health plans or payers, understand kind of the developing opportunities that we're looking at here in California and that are happening federally, but that might give you some sense of what you might do in your own state, and then really for all of us to learn from each other. This is most helpful for me if this is a conversation. I'm going to be speaking very specifically about California. I have very little information about what happens at the national or federal level. I'm little understanding of all the complexities and all the different states. So it would be helpful if at any time folks want to chime in and just say, this is not applicable to me, this doesn't make sense, can you help answer these questions? I'd be happy to do that. So here's an agenda of what I'll go over, but let's just get to it. So our board about 2 years ago made the decision to build into our strategic plan this healthcare reform initiative. And Serena Clayton, who is our executive director, has been working in this field for 14 years and has always made it a priority to try to find how school-based health services and school-based health centers can be better supported by the healthcare system. She has actively been engaged with local health plans, Kaiser, which is a big health provider and funder here, nonprofit funder and community benefit funder here in California, hospitals, etc., and really trying to find a way for school-based health center services to be reimbursed. Just so folks get a kind of concept, let me pause really quickly and talk about how California is structured. So our Medi-Cal, which serves our low-income families and children who are eligible for Medi-Cal, provides them with health insurance coverage. The state holds that money, contracts with health plans who they are the local healthcare provider, the local health Medi-Cal health plan. So we have multiple health plans across California, sometimes multiple health plans in one county, and so it makes it very challenging when we think about how we engage these health plans and talk about or advocate for school-based health services, because there are so many different players oftentimes in one county. Those health plans then contract with providers, with healthcare providers. So those healthcare providers are often community health centers, which sponsor more than half of the school-based health centers here in California, but they're also private providers, like the local doctors down the street, And Kaiser, which I mentioned earlier, is a big healthcare provider in California. They also serve in some counties some of the Medi-Cal patients as well, and particularly children. They've built in a big program to serve children through their health system. So that's how California is set up. And as I started to get into, for a long time for us, it's been a priority to really find a way to kind of crack that nut and really find ways that the health system can support school-based health centers. And 2 years ago, our board built it in as a part of our strategic plan and said, this is where we want to focus. Get out there, do this work. Let's find a way to be better at positioning school-based health centers in the healthcare delivery system and the healthcare reimbursement system. And let's find a way to get those folks to respond to some of our requests. So we broke that charge up into these different buckets. And the first is really educating the field. So that's our school-based health centers, our school health providers. The second is really educating the healthcare system, so kind of continuing that work that we've been doing for years, but being more strategic about it, making it a priority and building it into our work plans. Facilitating local pilot projects, and I'll get into what that means, and then advocating for public policies, and I'll touch upon some of those policies. The first thing I want to talk about is really I'm jumping over the educating the field, because what that looked like for us was really creating this work group of school-based health center leaders that we could check in with on a regular basis and let them know that this is the work that we're doing, this is what we're engaged in, this is what we see the role of school-based health centers, and we sent out kind of monthly healthcare reform updates on our work. We held several webinars, so that were some of the tasks that we did. I think the real lessons in educating the field will come out in the facilitating local pilots, so I'll get into that then. So where I want to start today is really on what we did around educating the healthcare system. We first started this work by saying, who are the people who can make things happen for us? And so we sat down, several of us sat down in our office and did some very rough brainstorming and really a huge brain dump in who we wanted to engage in this work. And initially, we identified kind of the leaders, the C-suite kind of executive folks at the local health plans that we wanted to reach out to. We knew people who were connected really well to them, so we knew we could set up some calls with them. We knew we could have meetings with them. And so we started there. And we quickly ran into several walls and closed doors, and it was really, I think, I don't know who expressed it this way, but someone said it really felt like just chipping away at a boulder with like a little ice pick, because these folks had their own priorities. They were not prioritizing adolescent health. They were really focused on their high utilizers, homeless populations, folks with multiple chronic conditions, people who had chronic illness and mental health. And for them, adolescent health and wellness just wasn't a priority, and so we weren't going to be able to move them. So that was kind of the first lesson that we learned. And so I think the takeaway and what I want to share with you all is really to sit down and engage in that. If you are committed to, if this is work that you are going to commit to, engage in that process of really listing out all of the different stakeholders that you want to engage with, and really map out what is realistic, what are the messages that are important to them now, what messages do you have that you think may be able to motivate them, and what's the reality of moving that work for each of these individuals. And for us, I think maybe about halfway through our first year, maybe even towards the end of our first year, we realized that our approach wasn't going to work and we had to really shift. So then we started to look at data, and so we said, okay, well, the messaging is not going to be helpful. Reaching these executives is not going to be helpful. Now let's use numbers, because we know health plans have a lot of data. They like data. They share data. California requires the health plans. The federal government requires the health plans to report on certain measures and outcomes. And so we said, let's start to review some of that data and see where that gets us. And so we reviewed most of the HEDIS reports for the health plans throughout California and really focused on their adolescent measures. So looking at things like immunizations, well-child checks, visits with a primary care provider in the last year for adolescents. And we then targeted those health plans that were really low in those areas and set out to meet with those plans and engage them in a conversation of how the school-based health centers might help them improve in those measure sets. And we had a little bit of success. I mean, we got the ear of several quality improvement directors. We got the ear of several people who were really interested in seeing these measures improve. And we started to make some different connections and started to build on some of our work. But we really realized, I think, at that point is that we needed internal champions who were going to carry this, because after that one meeting, that QI director was then going to go back and focus on everything else that wasn't related to adolescent care, because, again, they are really concerned about bringing down cost of care, and adolescents, even if they are not being seen, even if they have uncontrolled asthma, are not in the same boat as those folks who have multiple chronic conditions or are frequent flyers of the ER, or those kind of patients. So then we set out to identify those champions, and we really went after low-hanging fruit. And we said, look, what is the strength of school-based health centers? We know it, and what are the messages that we're trying to carry? We know it's very much around health education. So why don't we go and start to reach out to the health educators in these health plans, the health education directors, the folks who are responsible for overseeing health education programs or doing health education, and get them, get their ear and start to create our messages for them. Part of this was luck, so we had that in mind, but part of it was luck in the fact that we found one director of a local health plan here in the Bay Area. The health plan is called Alameda Alliance. We found their health educator. We're put in touch with their health education director, and she already knew about school-based health centers, knew about the great work that they were able to do, and was willing to connect us to all the right people, and actually set up a meeting for us where we were able to present to all of the Medi-Cal health plans in California. All of their health educators meet on a regular basis, and she was able to get us at that table and present about some of the great work that school-based health centers are doing, and start to have discussions around how they might partner. That opportunity was also really great for us because it was a chance for us to find out from all of these health plans, these different health plans from across the state, what their priority areas are, and they really boil down to two chronic disease prevention, two kind of chronic diseases, looking at asthma management and obesity prevention. So for them, those were two of their priorities. Mental health is also in there, but mental health is a carve-out. It's not something that the health plans directly oversee. They contract out for their mental health. So although it did come up, it wasn't something we were going to be able to move on, but it is something we're currently looking into, and I'll talk about that a little bit later. The other piece was around health education and really quantifying the health education that was being done at school-based health centers. So a lot of these health plans, for the first time, this was their first time hearing about all of these great programs that school-based health centers were providing, and they wanted to know how they could get that data. Like, that's important data for them. That's data that they report on a regular basis, and if they had an opportunity to tap into that, it would be much better. It would boost their numbers and make them look much better when they're reporting to the state. And so they wanted to know how many of their members were receiving, at least 15 minutes of nutrition education and at least 15 minutes of education around physical fitness through these school-based health centers. And then the last piece, really around patient engagement and access, is just the role that school-based health centers can play in helping to connect these members who may kind of, they're not responding to the health plans because the health plan, they don't have that trusted relationship. The patients, the youth don't have that trusted relationship with the health plans the same way that the school-based health center staff do. And so there's a real opportunity, and there was interest there for school-based health centers to play a better, a stronger role, or kind of enhance their role in reaching out to these patients that that the health plan may be missing. The real, before I get into the local pilot project, there was a lesson that we learned that kind of between like sparking all of this interest in health plans, and finally we're starting to talk to the right people, and finally there seemed to be some momentum, and then we ran into a wall on the school-based health center side. So we had been all this while talking about the strength of the school-based health centers and how well they're doing, and then when the health plans finally were ready to say, yeah, okay, let's see it, we reached out to several school-based health centers and found out that some of those ones that were in the areas of these health plans had closed, or some of them had stopped the great programs that they were running and that we were promoting, or those that did have really great programs didn't have the data that we needed to then take back to the health plans and say, here's the impact that they can have. So it was a real challenge and kind of a disappointment for us, and that here again, like, we were talking up the role of school-based health centers, and then when it came time to put the money where the mouth is, put things into play, we didn't have those good examples, and we didn't have those good school-based health centers to connect to these health plans. And so then we decided that we would really focus in on facilitating these local pilot projects, and then really strengthening the role. So I think that, again, the lesson we learned was it's more than just educating the field around the role that they can play, but we really needed to do a lot more TA and a lot more direct support and helping lift up the work of school-based health centers so that it's ready to be seen as beneficial in the eyes of these health plans. And this, as most of you all know, I mean, through the Hallways project, through your other projects, this is really hard work. It's very time intensive. It takes a lot of site visits. We're a big state. We have 243 school-based health centers. All of them are at different levels. It's a huge staff commitment, but since this was a strategic priority for us, we were committed to it, and we were going to move forward. So what we did, there are some of the lessons on the slide that you can look at. But the way we went about addressing this is we decided we would focus in and write and use a lot of our grant funding to help strengthen very specific programs of school-based health centers throughout the state, with the kind of larger lens that these school-based health centers, we were going to move them towards being ready to sit down with a health plan and say, here's what we're doing, here's why you should be interested, and here's the support we need to keep them coming, to keep them moving. So I'm going to talk about go into depth about several of these pilots, and then I'll talk about some of the ones that we have in the pipeline. So the first one was really around this kind of Kaiser pilot. We're calling it a Kaiser pilot. It's probably not a pilot, and it's definitely not a pilot in the same way that some of these other sites are, but for us, it was a good way to start to move the work with Kaiser. As I mentioned, Kaiser is a huge provider of healthcare here in California. A lot of their members are seen at school-based health centers throughout the state, and because they're Kaiser members, because they're Kaiser patients, the school-based health centers don't have a way to tap in and get reimbursed for the services that they provide. They will sometimes sign them up for what's called the Family Pacts program. This is a pregnancy prevention, reproductive health limited kind of coverage that we have here in California, that's really designed to help keep the unintended pregnancy rates low, but also address STI, in fact, STI, help help with STI, sexually transmitted infections, and reduce the number of new STIs. So the school-based health centers will sometimes sign those Kaiser patients up for those services when it's appropriate, but a lot of times they're eating the cost on a lot of this care, and specifically around mental health. So what we did is we worked with our work group to start to create a process for documenting and identifying these Kaiser patients that were being seen at several school-based health centers across California. So we worked with 4 school-based health centers, and they measured, they basically started to track all the Kaiser patients that were coming in and what services they were being seen for, and try to provide a cost to the school-based health center, how much it was costing them to provide that care. The reason why we were doing this is because of the model in Oregon, because we know in Oregon, Kaiser has actually partnered with the school-based health centers there to, my memory is a little bit shaky on this, but they have 2 different plans. One where they're reimbursing at a kind of capitated rate at some point, but they're reimbursing for services provided to Kaiser members at the school-based health center, and then they have a separate contract for kind of their it's not their Medi-Cal, but it's their Medicare folks who they're reimbursing for any service provided. So that's a little shaky, but the point is that there's precedent. There's something happening in Oregon, and Oregon folks can talk about this better than I can. But it's our understanding is that Kaiser has contracted with the school-based health center and is reimbursing these kind of both sets, their commercial patients and their Medi-Cal patients for the services that they're receiving. And so we want to see if that can be replicated here in California, and what we need to do to get there. And the first part for us was really getting some of this data. So you'll see from January to May, we worked with our sites. They did not receive any funding to do this. We helped them brainstorm how they might pull this data. We had regular calls with them that they joined. But for them, this is a huge opportunity, and they were willing to do it basically for free and give us this data and be a part of these calls without any real incentive, knowing that Kaiser wasn't going to fund them the next day. But they were definitely interested in it. So here's the results. You'll see that over the course each of the month. I think this is from one of the sites. This is definitely not from all the sites. This is an example of data that we got from one of the sites where they're serving a lot of Kaiser members and providing a lot of visits to them. This is around mental health. And so this is a huge need, and it's a conversation that we're continuing to have with Kaiser. We've started to get some leeway. I mean, we've started to have some movement internally with Kaiser, so we have some actual providers now who are looking at school-based health centers, looking at the role Kaiser's playing with school-based health centers, looking at information, sharing opportunities, or expansion and support. So this, although it's a very little data, it's over a very short period of time, has been compelling enough that we've been able to have some movement with Kaiser. So I think that the lesson that I just want to share here is, again, this is hard work. A lot of this data isn't readily available, and so it really requires sitting down with school-based health centers and thinking about where they might get this data, how they might get it, how they can report it. It required us holding this work, so collecting this data for them on a regular basis, reviewing it with them. So we had regular calls that we were talking about this data, and then trying to translate this into the financial cost, which is even more difficult, and not every site was able to do that. But even though it's very limited, I think that the data piece can be really compelling. The next project that I want to talk about is our Kern County, and again, I think this was an example of kind of getting lucky. We identified this school district in the Central Valley. Central Valley is a really rural area for California, very high need, high asthma rates, high obesity rates, a lot of, there's a high undocumented immigrant population, so and folks who are working in the field, so there's a lot of folks who are living temporary in one location and moving in and out, so it's difficult to manage a lot of their health needs. But we found a school that actually had through their school nurse, had a program in place where they were doing intensive asthma management for their students, identifying students who had uncontrolled asthma, connecting them to group care, and then doing individual home visits and assessing some of the home triggers for asthma for these patients. And at some point said, this is a lot of work that we're doing. A lot of these students are members of this local health plan, and we want to be reimbursed for this. The stars really lined up for this site because there was the health plan, there was a lot of pressure on the health plan to do more around asthma and more in the community. From my understanding is that there was actually an asthma-related death to a student in the area within kind of the timeline that this was all happening. And so the health plan, under a lot of pressure, said, we will support this work and we will reimburse for the services being provided to our members through this school. So when we found this, we thought this was a really great case study, unique. It's not going to apply to every health plan. Again, I think there are other circumstances that led to this. But we were able to start the dialogue with the health plan and with the school and with another school district that was located nearby of how can this be a replicable model and how do we expand this work to other students who are in need. And so we sat down with the health plan and identified, again, for them it's the same kind of issues, asthma and obesity, and we provided the school with some tools and resources, the school district with some tools and resources around what an obesity prevention program might look that was very similar to the asthma management program. And both this new school district and the health plan agreed to expand these services and this contract so that they could serve more students and provide this kind of quality care, intensive quality care to these students in these different schools now. So this is a model that we are actually really excited about because there are so many school districts in California. Not every school is going to build a school-based health center, but we know that school nurses, that school health staff can play a huge role in providing healthcare services. And so for us, this is an example of an opportunity to really replicate a best practice where there may not be a school-based health center. We're currently, the district is giving data directly to the health plan. We're not involved in any of the data gathering. We are staying in touch with the health plan so that we can collect their data and review their data and hopefully show some of the impact that they're having and the numbers that they're reaching and why this will be beneficial, why this might be beneficial to other health plans. So that's all. It's kind of in development still. We don't have any real data to share out, but we're hoping within the next year or two that we'll have some good data to share and then really take this as a case study to other health plans. So again, the lesson here is a little bit difficult because again, it was kind of on our part, we stumbled across this, but I think the point is to kind of keep our ear to the ground, like keep our eyes open for any and every opportunity, not be limited to just brick and mortar school-based health centers, but see other opportunities for school health services to be reimbursed in new and unique ways. The other piece and the role that we played is really providing the resources and sharing out best practices that could be replicated by the school nurse in this district. The last kind of pilot that I want to mention that is currently underway was one of those pilots that we initiated, that we started up, and through funding from a foundation, we brought together a cohort of 5 school-based health centers across California to do group obesity prevention and, intervention programming. Part of that, the core elements of this program being kind of a school-wide screening process, so having a way that you're reaching a large number of students. Here we focused on the 9th grade because that is a transitional grade. It's easier. 9th graders usually take some of the same classes. So focusing on the freshman class to do school-wide screening, doing a basic health assessment for each of those students and then providing their BMI, identifying those students who were, whose BMI indicated that they were overweight or obese, connecting those students to individual care with a provider, then if interested, getting a group of those students, getting a cohort of those students into group education, and then doing intensive follow-up for any student who didn't want to be in the group but was interested in getting individual care to the school-based health center. So that's kind of the elements of this program. We have, one of our sites is located here in the Bay Area, and which we've had, as I mentioned earlier, we have a strong partnership with the health educator from the health plan in this area, which is Alameda Alliance. She's really interested in expanding their health education through school-based health centers. And so the school-based health center has currently screened over 150 students. They've identified that more than half of those students are either overweight or obese. They've connected 20 of those students into a group program. They're now working on following up and doing that individual care to the other students. And in the process, identifying each of those students that are also Alameda Alliance members, and then documenting every time that student receives 15 minutes of nutrition education and 15 minutes of education around physical activity, as well as documenting their BMI and documenting that they have a kind of wellness plan in place with the provider. Our next steps is once all this data is gathered by the school-based health center, we will be sitting down with Alameda Alliance, with the health educator from Alameda Alliance, and sharing this out. And for us, I think this is what data information exchange looks like. Like, it's not, we don't have great systems to share electronically, and it will really be the school-based health center printing out their roster, printing out all of the documented, all of their documentation, and sitting down and reviewing that with the health plan to show that the school-based health center is having a real impact, and the health educator is committed to taking that information back to, the health education director is committed to taking that information back to her executive team with the hope that she will be able to contract directly with the school-based health center to provide these services in the next academic year. So those are the pilots. I want to pause in case there are any questions on any of those 3. Those are the ones that I feel like we have some momentum. They have been moving. There's at least something to report on, and the next ones I'll talk about are some of the ones that are in development. But if there are no questions, I'm happy to move on.
Well, I have a quick question. How did with the Kaiser pilot, what was the response to that data about the number of users, the number of visits? Was it compelling in any sort of way? It sounds like, for instance, the final pilot project that you gave an example of, the real intention in the end is that the health plan will take over some of those health education services. Has Kaiser indicated anything about what will be done or what the plan is with the use of that data from the Kaiser pilot?
That's a good question. I mean, I don't think the data was compelling enough. Like I said, it was a very small test. I mean, I think for us, our hope was like, yeah, we'll get some data. Maybe it'll be useful. We didn't think it would be compelling to Kaiser and like have them say, oh my gosh, this is a huge need, we need to do something about it. I think for the result has been that it's helped us start the the dialogue with Kaiser, and it's helped. So Cecilia Echeverria, who is the Hallways to Health program manager for Kaiser over, funds Hallways to Health, is also on our board and is also committed to the safety net and to community health centers and to school-based health centers. So that's also been a huge benefit to us, because she's at least been able to take that data and say, look, I know this is not a lot, but there are school-based health centers are serving Kaiser members, and we should start to look into it, and we should start to have that conversation. And she's been really helpful in keeping that dialogue going internally at Kaiser and really bringing up school-based health centers and the role of school-based health centers. So I think, again, even having a champion within Kaiser has been helpful. The challenge is that Kaiser, like many other hospitals, there's the community benefit side, there's the provider side, there's the membership side. So there's like different departments, and they all don't always talk to each other or coordinate. And there's even some legal issues around how they can talk to each other and how the funds can be used between departments, because the nonprofit can't go to support the business, and so or the community benefit can't go to support the business side of things. So I think having Ceci as a champion internally has helped us start to reach some of the providers in Kaiser, share some of this data, talk about our hopes. I think our next steps is to maybe do another kind of data dive around Kaiser patients being seen through school-based health centers, and really to look at what are some of the financial implications. That's one piece of it. The other piece that we've heard from providers at Kaiser and at some of the other kind of local hospitals is that they don't care about the financial implications. For them, the real message that sells is the care coordination. And so if we can show that their members are getting a lot of services through these school-based health centers, and they're not getting that information, like that's fragmented care, and that really, providers hate that. It's something that they can get upset about. It's something that they can get behind, and it may lead to them saying, we need to at least establish some kind of communication system with the school-based health centers. And our hope is that opens up the door to other opportunities.
Thank you.
I have a quick question. Yeah. So in terms of the development of these pilot projects, did you work with the health plans in conjunction to create the pilot projects? Did you receive the funding prior to? Kind of how did the whole fruition start, specifically with like the Kaiser and the Alameda one? Were they kind of in the know about the pilot projects, or did you present them to the health plans and then get the go ahead?
Yeah. So with the Kaiser pilot, we just did it. We started. And really we were responding to a need from the field, like from our field, like school-based health centers. It's a big issue for some of our school-based health centers. When I managed a school-based health center, the community I worked in was a mixed income community, and we had a lot of Kaiser patients that we were seeing on a regular basis. So for a lot of school-based health centers, it's a huge need, and we said, okay, well, let's do something about it. Let's start this kind of data pilot project, and let's try to get some good information that we can take back to Kaiser. We kept Ceci in the loop throughout the process. Like, we let her know, hey, we're doing this, and we won't share it out. Like, we're going to keep this internally. We'll share it with you, and we'll work with you to figure out how to move it forward. But it was something that we just said we're going to move forward and do. With the Kern piece, that's, again, I think that's a unique example where we stumbled upon something that was already happening. And again, our role was just to facilitate new relationships, introduce them to new opportunities, and really provide them with some of those best practices. And then for the Alameda Alliance, we reached out to the health plan first, found out what their interests were, what were some of the priority areas, and then we received funding for this obesity prevention program, and said, hey, well, if we can give funding to one of the school-based health centers in your area, would you be willing to agree to sit down and review some of this data with them? and they agreed to it. They said, yeah, of course we'd be open to that. So I think it was a little bit of both, a little bit of like, we're doing this, we're going to make something happen, and then approach the health plan or the health payer after, and then other times it was like, let's reach out to the health plan and see what we can, what's of interest to them and what we can move in their area. I think that the big thing was we were reaching out to all of these health plans and trying to promote school-based health centers, and we set ourselves up because we didn't have the good programs or data or information. Once those health plans said, well, let's move, let's do something, like, fine, let's sit down and talk about what this might look like. And so I think we had to be a little bit more strategic in saying, where are the strong school-based health centers? Where are the strong programs through school-based health centers or school health services? And then let's reach out to health plans in those areas.
Okay, thanks.
So we did shift a little bit. You know, it was a shift. Okay. So just really quickly, I want to be conscious of time. Some of the projects that we have in development, and some of these are going to be new to you, Jordana. They're going to be new to probably even Molly. But they are things that we're working on and hoping to build out. And I'm listing them here as examples. Nothing is confirmed. Everything is still in the works, so it's nothing we're really ready to share really externally yet. But we do see, you know, through our work with RICE as a hallway to health site, we've also been working with RICE on a separate asthma grant that they're working on, and we've that grant is through a partnership with the California Department of Public Health, which is really focused on asthma and reducing uncontrolled asthma and improving clinical interventions to asthma. They want to measure the impact of home visits in reducing asthma, reducing uncontrolled asthma, and improving asthma care for adolescents. So RICE, we found this out when we did our site visit. RICE has somewhat of a home visiting program. They do some health education to a local housing development, a low-income housing development in their community around kind of healthy eating and active living and, you know, healthy exercise. And they do some around asthma, and they're getting paid for some of those services. Their health plan, this is, again, you know, we continue to gather new information. We found out that one of the health plans in their area is actually reimbursing for health education, which is really unique. Health plans will reimburse for the primary care and not so much for the health education, but in this case they are. And so we are hoping to develop a pilot with RICE, with the California Department of Public Health, that will enhance some of RICE's work around asthma care and help them do more home visits and home assessments for their pediatric asthma patients, and share through that information, share some of that information with the health plan, and then California Department of Public Health will basically be able to use the health plan information and the school-based health center information to show the impact that home visits can have on controlling asthma. So again, this is something, there will be funding, there's potentially funding if it takes off through the California Department of Public Health, but for us it's a way to show the impact that school-based health centers have. Because they have these trusted relationships, they're able to get into the homes, and the way that health plan staff are not, and they can have a huge impact on improving health outcomes for patients. The second one is a project that we also have in the works, really looking at the role of school-based health centers in improving attendance. So we hope to pilot this with the Hope Clinic, and really doing, again, I think this is a little bit of identifying those best practices and helping them implement new processes for identifying students who are chronically absent, seeing if there are health issues that are causing those absences, creating interventions to address those health issues, and hopefully improve attendance. So this is not from the health payer side so much, specifically like looking at health plans or hospitals, but it is in terms of sustainability. For us, it's an opportunity to show the role school-based health centers have in improving attendance and getting interest from the school district to use some of their funds to support these health interventions, because they recognize that it's going to improve, it's to their benefit, and it's going to improve student attendance. So that's another kind of pilot that we have in the works. Oh gosh, sorry everybody. I'm going to stop sharing for a second while I find what happened to my presentation. Here we go. Okay, should be back on, right?
Yes.
Yep, you're back on.
Great, thank you. Thank you. So those are two that we have in the works. The other is we've seen a lot of good response from our obesity prevention program and the group program, and sharing that out as a best practice. So we have potentially we will be working with another health plan on the central coast of California that represents a large several counties in California, many school-based health centers within those counties. And this is an example of the health plan in that area holds a lot of the health education internally, has their own health education staff within the health plan, and was a little bit upset that was actually a little bit upset that the school-based health centers were implementing these new programs around obesity prevention, because they felt like they were also doing this work. And so we were able to sit down with them and say, look, this is an opportunity to not duplicate services, to really do a data dive and see, are these unique members that the school-based health centers are reaching? Are they the same members? If they're the same members, can you kind of think more strategically about where you have your health plan, health educators doing this work, and where you might support the school-based health centers either through increased staffing support or financial reimbursement. And if they're unique members, then there's the case to be made that the health plan should then be funding the school-based health center and reimbursing them directly for services provided. So that's an ongoing conversation. We've just started that. We'll be sitting down towards the end of the school year and really looking at that data with the health plan. Again, it's very basic. Here's our printout. Here's our members. Here's our patients. Here's your members. This is what we're doing. And then the last one that we're really excited about that's going to be taking off this month is we actually received funding directly from a health plan here in California to develop a new collaborative of 8 school-based health centers. And this is a planning grant, so it's really looking at the role that school-based health centers can play in addressing the social determinants of health. This will be really finding ways to assess patients. A lot of these school-based health centers are doing risk assessments for patients, but how are we assessing for kind of upstream issues and social determinants of health? Doing some community mapping, so helping these school-based health centers think about who they might partner with in their school-based health center, in their community, to address some of these issues. And then lastly, to create a kind of an action plan or a work plan that we can take back to the health plan and say, here are the issues we have identified, here are the partners, here's the work that's to be done, and hopefully that will turn into additional funding for each of these sites. So this is a new collaborative that we're launching. I think there are a lot of similarities with the hallways work. Some of the steps are very much the same. I think the difference is that this health plan covers a huge part of California, very different areas, some kind of suburban areas, some very rural areas, and so we will be, each of these plans will look very different. They'll be responding, the work plans will look very different. They'll be responding to the needs of each of the communities. So that's what we have in place right now. I do want to say, I think for us, you know, some of the hallway sites are challenging in the sense that the health plans that they're in the areas that they're located are somewhat challenging to work with. They do follow some of, you know, they're similar to this health plan that I mentioned in the Central Coast, where they hold a lot of this work internally, and it's harder to make the case of why school-based health centers should be supporting them. Or in the case of you know, Rice or Hope Clinic, there may be so many different health plans that it's hard to find the right one that covers the majority of the patients in that school, and so making the case is just really challenging. And this is work that we're committed to over the next year. You know, we're going to continue to build it into our strategic plan. We'll find ways to continue to engage these health plans. It's not easy. It's very difficult, and it requires, I think, a lot of intense staff support for both the school-based health center side and for the health plan side. And really quickly, I know we're running low on time. I want to save some time for questions. Going over the lessons we learned, I think I emphasized this enough. You know, data is really key. Making sure that school-based health centers have data on their health plan, that they're reviewing it frequently. It may require you to kind of help collect some of this de-identified data. Communicating always, like keeping health payers, health plans in the loop, letting them know the great work that school-based health centers are doing, how they might partner, how it can benefit them, making sure that they're on any communications you're sending out. All of this is really key. And then realizing that none of this is going to happen overnight, that it's going to be a long process, and that it's going to take us a while to really build replicable models that other health plans might be interested in. The last piece that I don't want to spend too much time in, but I do want to mention as opportunities for us, is we know there's a lot of movement around accountable communities for health. So there's funding at the federal level. There's very specific funding for California and developing these accountable communities for health. Here in California, the model is going to be really based on, again, identifying what the health needs for the community are, and then the collaborative, the accountable community collaborative is really charged with designing interventions and supports to address those health needs. We want to make sure that school-based health centers are at the table. We want to help. We want to help kind of create plans or work that health centers can do to really make sure that they're at the table and really lifting up some of the best practices. So that's work that we'll be engaged in over the next year as those fundings kind of are released. And then the last piece is around our policy around there's current state legislation that's in progress around sugar-sweetened beverage. We're not really calling it a tax, but we've listed it here as a tax. So it's a way to tap into funding from the purchase of sugar-sweetened beverages, and then identifying a pool, identifying ways for that funding to support health initiatives and health interventions. And so school-based health centers will be able to apply for that funding if this bill passes, and implement some of these programs that I've discussed today. So again, I think those are kind of the policy side, the work that we're doing around sustainability. And with that, I will. Oh, one other thing I did want to mention really quickly that I didn't include in the slides is that I mentioned earlier how mental health for us is a carve-out for the health plans, and we currently are partnering with a consultant who is helping us dig deeper on what the health what mental health and contracting looks like with health plans and how school-based health centers can play a larger role. So we hope that towards the summer we'll have some good data on the responsibility of health plans, how they develop those contracts to provide mental health services, and how school-based health centers can be, again, should be at that table and be a part of those contract development, be built into those contracts. And that's it.
Thank you so much, Juan. It's great to hear about, especially those new pilots involving Rice and Hope, especially since Rice and Hope kind of don't necessarily primarily serve the student populations at the schools they're co-located at.
Yeah, I think this will be a chance for us to really improve some of that work that they're doing, and give them a little bit of financial support and incentive to do so. So, yeah, they're exciting.
And Hope specifically, it seems like the principal was not necessarily bought in or connected to what's happening at the school-based health center. So to get her, involved with the attendance piece is awesome.
Yeah. Yeah, and I mean, I think that's where again, the messaging is different for each of these stakeholders, for each of these folks who might sustain some of these programs, and it's really about crafting and developing the messaging that works for each of them, and being ready to pull that out and having very clear examples.
Hey Juan, it's John. I'm curious to get your thinking about the policy change focus at the sort of local level versus state policy. You clearly made the decision that the money is going to go from the state to the plans, and therefore you have to leverage the relationship between the school-based health centers and the plans. Have you thought about changing where the leverage point is at the state level, where there is an opportunity to create stronger policy incentives or disincentives, if you will, for relationships between plans and school-based health centers, where the onus isn't on the school-based health centers to develop the relationship?
Yeah, I mean, we've had a statewide policy agenda for the last. I mean, I think these last 2 years are the first time that we were very deliberate in not having a very specific statewide policy agenda. And I think the reason being that California is so difficult. I mean, like any state, I'm sure, but we just felt like California is so difficult to move anything at the statewide level. There are other priorities, health priorities that were being focused on at the statewide level, specifically around kind of the Medi-Cal expansion. Number one, just general expansion through the Affordable Care Act, but now that the focus has really been on expanding Medi-Cal to undocumented children, that it's kind of difficult to really talk about anything else. I mean, I think that's been the primary focus of a lot of our state legislators and state stakeholders. So this is not my primary focus area. So I want to acknowledge that I don't know all the decisions that were involved in that, but I know that we did feel like we had been putting so much work at the state level for so many years and not seeing the results that we had hoped. And at the same time, we saw a shift in kind of California in many ways. Decisions, funding was all being moved from the state level down to the local level. So our education funding, now local school districts have more input, and they're able to have more control over what their education funding and spending looks like. The role of counties in providing mental health has increased. So I think we recognize that a lot of this work is just happening at the very local level, and as much as it really kills us because it takes a lot of staff time to develop this work at the local level, we had to do it. because we were able to see more momentum at the local level and kind of creating these partnerships and engaging in this dialogue directly between school-based health centers, health plans, sometimes county health departments or healthcare agencies, and the benefits. I think we saw more benefits more easily through that process. We have also continued to engage the California Department of Public Health, let them know about what we're doing, and I mean, the response has been, this is great, show us examples, we'll share it out, we'll share the good news, we'll spread it out, but it has been a challenge to really to identify, like, how do we hold health plans accountable, how do we have the state or Department of Public Health really play a larger role in forcing, for lack of a better word, health plans to sit down with school-based health centers. We don't know how that can happen.
Do you have a sense of, obviously you have a sense of California, but, I guess in Georgia we heard one of the hallway sites indicating that they have a relationship with some of their health plans, but I wonder nationally how many school-based health centers have a relationship with their health plans, or how feasible that is.
Yeah, for us, I don't have. I mean, I obviously don't have a sense of the national level, but I can say that for a lot of our school-based health centers, they had no relationship with their health plan. Like this was the first time they were, for some of these sites, it's the first time that we're having them talk directly to their health plans. Like, their sponsor agencies, if they're represented by a community health center or a federally qualified health center, their sponsor agencies are definitely talking to the health plans, and the health plan view is always like, yeah, we support the school-based health centers because we reimburse their sponsor agency for all the patients that they have in their network. And our role is really like, let's sit down with the health plans, with the school-based health centers, let's engage in that direct communication. And for a lot of our sites, it was the very first time they've ever done any of that.
Okay, good to know. Stacy, do you have any questions for one?
I do. My one question, I want to go back. Data it seems like a huge piece of this, and you had mentioned a few times that the sites, didn't have the data that they needed, and thus, the formation of the different pilots that were pulling and looking at different data. But back at the very beginning, when you realized that the lack of data that you were wanting to inform those conversations with the health plan wasn't there, were you able to identify really what that lack of data was about? Was it that they weren't capturing, the visits or whatever type of data at all, or was it they were capturing it in, case notes or patient notes and not in a system that allows you to pull it, or that it was being captured kind of inconsistently by provider? Like, were there any themes in terms of why that data wasn't there, or was it all over the board?
I think it was a little bit all over the board. I mean, I think for most of the sites that we were working with, they were capturing this data and they didn't know how to pull it, or they didn't have a really useful, effective way to pull this data. And so it was, I think you're right in that a lot of them, let's take physical activity and nutrition education, for example, they were capturing this in their notes. Because a lot of the sites were not billing for the health education, there's no way for them to kind of check that box and then submit that box to the health plan so that the health plan gets that data. So they may check the box that says we conducted a visit, we provided some care around obesity. I don't know all the exact codes, and then in their notes they'll say provided education for this, provided these materials, and so that information, through those, you can't really pull those notes from their records in an effective way. So we really had to give our sites some very basic data tracking tables, Excel sheets, where they are having to type in, after the patient is seeing, then go back and do kind of double entry and type in patient X seen, education provided, number of minutes, etc. And that's, I mean, that's how we're kind of going about it. I think, so yeah, I think for the most part, they don't have a good process for documenting a lot of this data, and then if they do, they don't know how to pull that data in a way that's effective or useful.
Yep, okay, that makes sense. So my other data question is kind of on the opposite end of the spectrum in terms of data, and more around, I realize kind of it seems like the data that's being looked at is to demonstrate the case to the health plans of, you know, these are the number of your beneficiaries that we're serving, and these are the services that we're providing. Have any health plans started to push or mention like outcome data in terms of the services provided and the patient outcomes, or has that not even been brought up by anybody yet?
We're not even there yet. Like right now, it's all about utilization. Like there's the health plans. I mean, and so that's another, I think another good kind of data challenge from the school-based health center side. Some of our school-based health centers, you know, when the youth come in, mostly high school youth, if they're coming in by themselves, they, you know, what's your insurance? I don't know. You know, where do you go for the doctor? Maybe Kaiser? I don't know. You know, and so I think some of them have real challenges in documenting what type of insurance, and so they're not even able to pull utilization rates for health plan members because they don't. Oftentimes, that information is not very good. And, you know, in cases where they are signing up patients for Family Pack because it's A, easier, and B, because it may be, you know, Family Pack, again, covers those confidential reproductive health pregnancy prevention services, so it's a confidential visit, then that data is, even that's not going to be helped. They're not going to be able to identify that patient moving forward as a health plan member. So I just want to bring that up because that's been another challenge that I didn't mention, is that, you know, the school-based health centers are having to run all of their reports on the patients they've seen, let's say for obesity prevention or weight management, and then go through all of those ones that they haven't documented the health plan or health insurance status for, and do a little bit more work in finding out if those patients are the health plan members. So I feel like we're such at the basic level of utilization and reporting utilization, and it's a challenge from the school-based health center side. The health plans don't have a good way of knowing how many of their members are being seen at the school-based health center, so it's a challenge on their side that we haven't even got to the health outcome discussion yet.
Yeah, no, that makes sense. Yeah.
Hey, Stacy, it's John. It's a great question. What do you have in mind when you ask about outcome? What are they collecting that are from the plan side that has an outcome feel for it other than process measures?
Well, I think like reduced BMI, different clinical measures like that. So over time. So, and it makes sense that they're not asking for that yet because of where, you know, the conversations that you're in. And I don't think it's anything to be, you know, put big flags up now, but I think it's something to kind of keep in mind. I'm thinking, Juan, that as these sites are now, and you're working with them to create these tables and for them to revise any data collection that they're doing to be consistent and to capture what's needed to make the case, that, you know, just to keep in mind, I think that maybe down the road health plans, as they're asked to invest more in, and hopefully agree to invest more in these types of services, that may someday ask, okay, now, if, you know, show us the impact of this investment. So just something to keep in mind, and I don't think it's anything to go crazy about now, but as data collection mechanisms are changing, it's a good opportunity to kind of think 10 steps ahead sometimes. So that was it. That was kind of the intention of asking that question.
Yeah, I will say that I think our opportunity our most immediate opportunity there is around the asthma work. Because the asthma work, we do have some of the sites, some of our higher performing sites, and it's not many, that are part of our, we have an asthma collaborative where they're actually improving some of their asthma supports and interventions. One of the measures that they are starting to look at is, I think, like number of asthma attacks that, this is self-report data, but that's one. Knowledge around using their asthma, when patients need to use asthma medication, and are they using it appropriately. So that's another, again, not a real health outcome, but I think more of a knowledge kind of development, increase in knowledge and skill. The other one is we do have one around ER visits and reduced number of ER visits. So that I think is something that would be compelling to the health plan, because it's showing that these programs are having a real impact on students having asthma attacks and having to rush to the ER. Like the school-based health center is helping them control their asthma, has helped them control asthma so that they're avoiding those unnecessary visits. So I think that for us, we are moving in that direction with the asthma. For the obesity prevention and intervention program, it's such a harder thing to measure because BMI is such a bad indicator, particularly for adolescents as they're growing, as they're developing. So we've talked with, we have someone on staff with this program around maybe doing something around waist size, and that could be a good measure, but it's not something that the health plans are really looking at right now. Like they're looking at BMI and so yeah, I mean, it is something we are definitely struggling with. I think there is opportunity with the asthma program in the near future, and hopefully something we can move and start to track better.
It's great.
Any last thoughts? Any last questions? That was a lot.
Good question, Stacy. Thank you.
Yeah, thank you so much.
Yeah.
Juan, are you open to questions over email as well from the group?
I am open to questions over email. Trying to get this thing to work again. So there's my email. Folks can feel free to email if you have additional questions. We do have a lot of this information and some of our work up on our website. So there's a link to the website there. But yes, please feel free to reach out if you have additional questions. For us, it's hard work, but it's exciting work.
Certainly. Yeah. Okay, well, thank you so much for sharing. Sounds like there's a lot of rich material here for the other state affiliates and thinking about where we're going to move with hallways for the sites too. What are possibilities of relationships to grow, data to begin to collect and track meaningfully. Sounds like we have a lot of work on our hands too. But thank you so much again, and we will reconvene with Maureen's presentation on the 13th. We're also scheduled for a call on the 11th as a regular state affiliate call, so I'll be following up with you guys about that, and if and when we will still conduct that, because I know this is a lot of time in the next 2 weeks. So thank you again. And
thank you.
Look forward to talking to everyone.
Thanks, Juan.
Thanks again, Juan.
No problem. Thank you all. Bye.
That's better.
Thank you.